So welcome back, guys. This is Dr. Ajinkya here, and before I start this video, I would like to thank all of you guys out there, my subscribers out there who watch my videos. Because of you guys, this channel is a huge success so far. That helps me a lot to teach you guys a lot of basics in ENT and skull-base surgery, different surgical aspects, different surgeries, radiological points of view, the basics, and also teaching you the neurosurgical point as well. So as you must have seen in today's video, I'll be talking about the basic concepts in MRI for beginners levels. So how you can actually basically learn to read an MRI scan, basic points and different sections and different types of MRI scans, how you can interpret an MRI scan in different conditions such as, so I'm going to talk about different conditions such as the olfactory esthesia neuroblastoma, sinonasal carcinoma, nasopharyngeal carcinoma, mucocele, JNA, inverted papilloma, different types of CSF leak and AC polyp, and various other benign sinonasal masses. So in all these conditions, how does an MRI actually help in identifying the pre-op and the basic concepts? It helps us understand more about the condition. So I'm going to talk about the very basics of MRI. So the very first thing about the basics in MRI is about this photograph, as you can see on the screen right here. So to understand the basic concepts in MRI, you need to understand that the first thing is that when you hold an MRI scan, you should know for sure that this scan is definitely an MRI scan and not a CT scan. So I've done a video recently where I've shown basic points of how you can differentiate a CT scan from an MRI scan, so for which I'll post the link of that video in the description panel below. So make sure you watch that first if you don't know how to differentiate a CT and an MRI. So once you know how to differentiate that, whatever structure which is in front of you right now is the MRI. Now, the first thing, when you know the MRI, you should know the different sections in the MRI. So for example, as you can see on the screen, this is a T1 weighted, this is a T2 weighted, and this is a flare image. So for basic beginners, they all should know about the basic difference in the case of T1 and T2 weighted image. Now basically T1, now this is an axial scan of the brain. Now I'm going to be showing you the MRI PNS and the brain together, so that this is very easy for the skull base and the neurosurgeons as well, those who are in their residency phase. So this is T1 and this is T2 weighted image. Now basically the T1 is mostly for the anatomical study and the T2 is for the pathological study. So the basic points which I'm going to show you how to identify is that, now remember that the MRI does not show bone. It is only for soft tissues and fluids. So mainly it is not showing bone, so you cannot see bone anywhere in the MRI scan. So whenever you get an axial, sagittal or a coronal section of the MRI brain, you cannot see the skull. What you can see over here is the thick, dark, pitch black rim over here, which you can see. That's the bone, that's the skull bone. And whatever you see over here, the bright white dense structure over here, this is nothing but the scalp and the subcutaneous tissue. So do not confuse with that. So you always have to remember. And you can actually see the brain parenchyma with the sulci and the gyri and the ventricles as well. You can see them on the CT scan as well, but not that clearly and not in much detail. So the first thing is you have to locate which scan is that, and you have to look for the brain parenchyma and the ventricles. So in the T1 section, the CSF is always going to be dark because it's for the anatomical study. So the CSF is always going to be dark in T1, and as you can see over here, this is the ventricle over here. The CSF will be always bright white in case of T2. Okay, so unless it's a flare image, now the flare is nothing but a T2 itself, but with fluid attenuation. Now the flare itself stands for fluid attenuated inversion recovery. So in case of that, it is nothing but a T2 image, but the fluid will appear as dark. So all the characteristics of T2 are the characteristics of flare, except for the fact that the moving fluid, which is a CSF, will appear as dark. So moving on to my next slide, this is a table which you have to remember. If you want to take a screenshot, you can take the screenshot, because this is really important for your long-term study in radiology and as a surgeon as well. So these are the tissues. So if this is T1 weighted image, that's T2, and that's flare. So in different conditions, different tissues, how they look like, you should be very well aware of. So the first thing is we're going to talk about the CSF. As I spoke about some time back, T1 will show dark CSF, T2 will show bright, the white matter and the cortex. Okay, now this is really important. Now in case of the cerebrum, the white matter is actually inside and the gray matter is actually outside, and which is the opposite in case of cerebellum. So what you can see over here is all the white matter in the center, the brain parenchyma, and the cortex, which is the gray matter, is kind of outside. So as you can see over here in the T1 weighted image, the white matter is kind of bright white, and as compared to the T2, you can see the white matter is not bright, but it is actually dark gray. Okay, so this is what same it is mentioned over here, that the white matter in T1 is kind of light, matlab it will appear to be as bright, and in T2 it will appear to be as dark gray, which was evident, quite evident in this case. Okay, so same thing is the cortex, which is the outside gray matter. So in case this is the cortex over here, the outside structure, which will appear as gray in T1, and in T2 it will appear as light gray. So as compared to T1, the cortex will be slightly bright, light gray. Okay, and this will be normal gray. So as you can see over here, the cortex is kind of gray, and here it is kind of light gray, so it's kind of bright gray over here in T2. So these are the minor differences which you have to keep in mind, because in some time I'll let you know the importance of that. So the next thing is the fat. Now this is a really important point. Now the fat, or wherever you can see fat within the bone marrow itself, in case of T1 it is gonna appear as bright, and in T2 it is gonna appear as light. Now bright is actually excess white, and light is actually bright itself, but kind of the intensity is kind of low, but still bright. So the fat will appear as bright on T1 and light on T2 as well. Any inflammation such as infection or demyelination, or you can say meningitis, it will appear as dark on T1 and bright on T2. So in case if there's any post-traumatic inflammation or any edema, in case, or maybe in case of infection like meningitis, the inflammation will appear as dark on T1 and bright on T2. So you have to remember this point, is like really important. And flare image. Now what is flare exactly? Flare exactly is nothing but all T2 except for the fact that the CSF is going to be dark. So that is really important. So this is, you can just sit there and you can revise this for like 3 to 4 times. Keep the concepts clear. You will definitely have your concepts in MRI very much clear. If you understand the concepts of T1 and T2 and flare, I think half of your radiology aspect in MRI is almost done. So I hope this concept is really clear for you guys. Then moving forward, the same T1 image. Now in that same T1 image, there are 2 subtypes. This is a normal T1 weighted image, and this is the same T1 but with a post contrast. The contrast used here is the gadolinium. Now as I said before, that the T1, the brain parenchyma, that's the white matter, is going to appear as bright, and the cortex is appear as gray. And the same thing will appear kind of bright white but less bright white, but the peripheral blood vessels will show contrast enhancement, which is not seen on the normal T1. So this is a gadolinium, the contrast which enters the blood vasculature in the brain, and that appears as hyper intense slit-like blood vessels, which you can see over here. So that's the basic difference you can have in a normal T1 and a post-contrast T1. So you have to mention that the gadolinium enhanced bright signal in the blood vessels is always evident in the brain parenchyma and the periphery. So that's one important point. So if you're given a scan of T1, a normal T1, you will see all those features which I spoke about some time back. But if it's a T1 post contrast, you're going to see all the blood vessels flaring up. So that's the main point you have to remember. So all the features are going to be same, except for the fact that there's an additional hyperintensity in the blood vessels because of the bright signal with the gadolinium. So moving forward, just as we spoke about the flare image, which is nothing but the T2, except for the fact that the CSF is quite dark inside, we have one more subtype of an MRI, which is called as the diffusion weighted image. Now, the diffusion weighted image basically works on the principles of the diffusion of water molecules in a particular tissue. So because the magnetic field in the MRI kind of works on the water molecules, the ions and everything. So that's a basic principle of working mechanism of the MRI, the magnetic field, right? So what happens is that if in case there's a tumor in the PNS, that's any nose or sinus or brain, intracranial, there's a malignant tumor. So the place where the tumor exactly is, that place will be very low on water. The H2O, the water level in that tumor will be very low as compared to the normal tissues surrounding it. So the cellularity, the water level in the tumor is going to be very low. And if the water in that particular area is going to be low, the diffusion in that particular region is also going to be restricted. So if you happen to have a diffusion weighted image, and if there's a malignant tumor somewhere, the restriction, or you can say the water restriction or the diffusion restriction, is going to be a lot. So that is going to be appearing as the hypointense area. So that is really important for differentiating the malignancies most commonly used in the inverted papilloma and malignant conditions of the PNS and brain. So in this photograph, as you can see, it is the acute infarction is seen on the diffusion weighted image. So this is really important to identify the areas of malignancy for on diffusion weighted image. So there's one more subtype after diffusion weighted image, and that is the apparent diffusion coefficient, actually ADC, apparent diffusion coefficient, which I'll talk about sometime later. Which I'm going to show you a live MRI scan for that. So this is also one more photograph which can help you if in case you are going for the MRI of a neck, because the ENT surgeons are also head and neck surgeons, so they may go for a neck MRI. So in that case, the T1 and T2 are going to appear like that. So the CSF, the muscle, the spinal cord, the fat, the disc, the air, they are going to appear as shown on this photograph over here. The inflammation, as said, is going to be dark on T1, and T2 is going to show a bright one. So you're going to have a screenshot of this as well. So this basic points are like really important for you guys, for beginners in radiology, and for those who are new to ENT and skull-based surgery. So I hope so far the concepts of the MRI is so far clear, and this is nothing but the indications, the limitations, and the contraindications of the cranial MRI. So you can take a screenshot of this for the indications, then you can take a screenshot for the limitations, and then you can take a screenshot for the contraindications to the MRI, because this is like this comes as a short note for the ENT surgeons and the radiological, so the residents, because this is kind of advanced thing for the ENTs and the radiologists. So the contraindications and the indications are like really important. So you can have a look at this. So moving on further to the basic, so what I'm going to do here is I'm going to show you different MRI sections, how you can actually read an MRI. So after having known the basics of MRI, starting from T1, T2, then the diffusion weighted, then the ADC, that is the apparent diffusion coefficient, which I'll be talking about in some time. Then the flare image, then the T1 post-contrast image. So once you know the basics of the MRI, then I'll move forward with the steps of how you can read a proper MRI. So as you can see on the screen, this is an MRI of a patient whom I saw sometime back in my surgical career in my hospital. So what you can see over here, this is the coronal section of a patient. Now, as you must know that this is a case of a T1 section, because the CSF and the vitreous humor, the globe, is kind of appearing dark. So in case this is a T1, so the vitreous humor and the CSF will appear dark in case of T1 sections. And as I spoke, the brain parenchyma, the white matter, is going to appear as bright white, and the cortex is going to appear as gray, which is the case over here. So this is how you identify which scan exactly you've been given, whether it is T1 or T2. So first of all, you always have to remember, now basically the basic concept, it's just like CT scan. When you order an MRI scan, it should be around 0.5 max to max 1 mm scan, and it should be in all 3 different directions. That's the axial scan, the coronal scan, and the sagittal scan. This we have is the coronal section. Now this is the most anterior aspect. Now this is the case. So the bone is not going to be visible. It's all about the soft tissue and the fluid content in the sinus. So if we keep on going posteriorly, you can see the frontal lobe of the brain over here. You can see the frontal sinus over here. So if I can just zoom this for you guys. Now this is the thick, bony, black, pitch dark shadow over here. That suggests that's the skull base. That's the bone over there. So whatever black you see is going to be bone and the air. So we all know that if we correspond this very same image to a CT scan, we're gonna see a thin to thick plate of skull base bone over here, which separates the orbit and the frontal bone over here. Okay, the frontal lobe, and you can see the frontal sinus in this case. So that's the frontal sinus. On the left side, it's a huge frontal sinus. So that's the right frontal, that's the left frontal. These are the nasal turbinates, which are going to have bright appearance to them. So this is the eyeball, that's the globe. If you keep on going behind, you're going to start seeing the frontal lobe, the 2 cerebral hemispheres. The middle turbinate is appearing in the picture right now. That's the nasal septum. Now, the nasal septum is a bony structure, so it's going to be visible as a black central line. And on either side, we're going to see the mucoperiosteal, or you can see the mucoperichondrium over here, the 2 layers. So it is very quite visible over here. This is the nasal septum in the midline, and we can see the mucoperichondrium and the mucoperiosteum over here. That's the mucosal flap. So if we keep on going behind, we can keep on seeing the ethmoidal area. That's the maxillary sinus over here. So we see bone as black and air as black. So we need to differentiate properly which is bone and which is air. So we can clearly see the bone over here. That's the demarcation line. So in cases of encephalocele or in cases of olfactory neuroblastoma, for which I have the images of the MRI as well, I'll show it to you. So we're gonna be careful if there's a prolapse of the brain tissue over here. There will be a discontinuation in the this black line over here. So that's a clear evidence on the MRI that there will be a bony breach for the olfactory neuroblastoma and any other meningoencephalocele, etc. So this is the eye globe over here. You can see the eye, the musculature, the musculature over here, the periorbital fat, the periorbita. That's the floor of the orbit. That's the roof of the maxillary sinus. So this is basically similar in all terms, the exact way where you try to read a CT scan, except for the fact that the bone will not be visible. Rest is all the same. So you just have to follow the normal standard anatomy. You keep on going behind. The musculature is going to be quite visible over here. That's the medial rectus. That's the superior oblique. That's the superior rectus. That's the inferior rectus, and that's the lateral rectus. That's the eye globe here in the center. And you can see at this particular area, the area of the anterior ethmoidal artery, the beaking is quite evident over here. So you can still keep on going behind, and you will eventually enter up into the sphenoid sinus. Now, you will not be able to visualize the intersphenoidal septa because that's a bony structure. So you're going to see the sphenoid as a whole structure over here. And this is the temporal lobe of the brain, the temporal uncus. That's the brain over there. We can see the ventricles over here. That's the temporal lobe over here. Whatever circular voids you're gonna see over here, that these are all but the blood vessels, the branches of the internal carotid artery in the brain. So that's the sphenoid sinus over here, and eventually you're gonna see the area of the carotid artery, the branches of the carotid artery over here, and the area of the pituitary gland over here. Okay, so that's the cavernous sinus basically. Now the study of choice for cavernous sinus is basically T1 post contrast, because that's going to fill up the entire cavernous sinus, and that's going to appear as bright white because of the enhancement of the venous blood, because of the uptake of the enhancement, the contrast, so which is the gadolinium. Now the gadolinium is to be taken as 0.5 ml. The maximum concentration of the gadolinium is about 1 millimole, because if you exceed the concentration beyond 1 millimole, that can act as a toxic substance. Now many people do not know that if given an extra dosage, the gadolinium may act as a harmful substance, may cause meningitis, also may cause about some renal damage. So if patients are having pre-existing renal damage, they should not undergo the gadolinium clearance. Okay, so this is the area of the cavernous sinus over here. That's the area of the pituitary gland over here, and that's the ventricles over here. So this is the area of the brain. This is the nasopharynx. That's the choana. So this is how you basically read the MRI, similar to a CT scan. So okay, that is how you read a basic T1 scan. Now I'm going to show you a different T2 scan. Now what you can see on the screen right here is a T2 scan. Because why T2? Because the vitreous and the CSF is quite bright over here. Now if I expose the so once you have to locate the vitreous humor and the CSF. Now you can see the optic nerve over here. That's the optic nerve, and you can see the clear CSF around the optic nerve. That's a normal condition, because the CSF will be present around the optic nerve, because the optic nerve is surrounded by dura, and there is CSF around the optic nerve throughout its length. So this is a normal phenomena to see the CSF around the optic nerve. So that is what you see. This is a T2 scan. So this is the axial T2 scan. Now if I can show you the coronal, okay, this is a T1 scan. Okay, if I can just show you the coronal in this patient. So if we go from the most anterior aspect to the posterior aspect, you're going to see the hyper intensity of the globe because of the vitreous humor. That you can see the lens over here. The lens will be always opaque. No matter what contrast you take, the lens will be always black and opaque. So this is a frontal sinus, which you can see very clearly over here. And you can keep going behind. You're going to see the same structures, and you can see the peripheral CSF over here. That is going to appear as bright white. So it is similar in the nature with T1, except for the fact that it will appear as bright white for CSF and the vitreous humor. The rest is always the same. And as you can see over here, even if it is T2, the area of the cavernous sinus will not be flaring up, because this is not a post contrast. Unless this is a post contrast film, the cavernous sinus is not going to enhance. So this is nothing but a CSF which is appearing as bright white. Okay, so if I show you a different scan over here, there's one more subtype for the MRI. This is the MRI venogram. So that's the MRI venogram. Now the MRI venogram is really important to study the anatomy of the dural venous sinuses of the cerebrum. So what you can see now, I have done a previous lecture of the dural venous sinuses, where I've spoken about the entire anatomy and the 3D anatomy of the dural venous sinuses. So once the indication for going for a MR venography is, for example, if a patient is undergoing a surgery for meningoencephalocele and a surgeon has repaired the meningoencephalocele, but the patient is still having constant CSF leak, under high pressure CSF leak, recurrence of the CSF leaks where everything else is normal, but when the patient's MR venogram is done, then you can see the one of the sinuses, the dural venous sinuses, is kind of obstructed or having a chronic obstruction, for which the absorption of the CSF gets hampered, and that leads to the excess CSF. So the decreased absorption will lead to excess amount of CSF in amount. So that will lead to constant CSF leak somehow because of excess pressure. So in this patient, as you can see over here, this is a patient whose MR venography was done, and to my surprise, this patient's right, as you can see over here. Okay, so that's the confluence of the sinuses, and that's the anterior aspect. The patient's transverse sinus was actually absent. As you can see over here, this structure is kind of really absent. That is nothing but the patient's transverse sinus on the left side is kind of very much obliterated. This is the transverse sinus over here. That's the sigmoid sinus over here. And that's the confluence of the sinuses. That's the transverse sinus. That's the sigmoid sinus. That's the IGV down below. So this patient's transverse sinus on the left side is kind of actually not present. The sigmoid sinus can be seen over here very much clearly. So this is really important in cases of the certain cases that you need to do the MR venography. That's the superior sagittal sinus, that's the inferior sagittal sinus, that's the straight sinus over here, and that's the confluence of sinuses, and that's the transverse sinus over here, and that's the IGV over here. So these are all the different types of the MRI, and there's one more type of the MRI which I was talking about, is the apparent coefficient, apparent diffusion coefficient. That's the ADC. So this is how it looks. So it is basically a measure of diffusion of the water molecules in the tissues perspective. So this is how you can measure. This is how the ADC actually looks like. So I showed you some time back on basically how the diffusion looks like, right? So this is how the diffusion weighted image looks like. So there's one more variant to this diffusion weighted image, is the apparent, the ADC actually, which actually looks like this. So whenever you see a scan like this, it is definitely the ADC. And as you can see over here, it is the typical appearance. It actually looks like pixelated. So it has got a pixelated appearance. So this is nothing but the ADC. So you can have a discussion with your radiologist about the importance and significance of the ADC in diffusion of water molecules in cases of malignancies. Basically, most important for the ENT surgeons is the malignancy, mostly in cases of sinonasal carcinomas and the conversion of the invoid papilloma. So in those cases, the diffusion weighted image, the ADC images are like really important. So this is how it looks like. So I hope now all the different variants of the MRI, that's the T1, T2, post contrast T1, then the flare image, the diffusion weighted image, the ADC image are all clear for you guys. So next time you go, you can discuss all this again with the radiologist, and also about the MR venography as well. Now, moving on to one more variant is the MR cysternography. Now, if I can, I had a patient for whom she had a CSF leak. Wait a second. I guess she's the one. I guess, okay. Yeah. So there was a female patient. She had complaint of CSF leak, spontaneous CSF leak. She was a young female, not obese, by the way, because if a female is in mid 40s, she's obese and she's having a spontaneous CSF leak on one side, most likely the diagnosis goes towards the empty sella syndrome because of the spontaneous high pressure leaks. But she was a young female, but she did have a spontaneous leak on the unilateral nasal discharge, and it was confirmed to be as CSF. So we thought of doing and that was intermittent in nature. So before trying to operate on her, we tried to do a MR cysternography for the patient, but to my surprise, the MR cysternography did not pick up any sort of CSF leak over here. So I'm going to show you how to read an MR cysternography. So whatever you're seeing on the screen right now is the MR cysternography. Now this is a T2 scan of the MR cysternography without the contrast. Here the contrast was, I think, not used. So this was a normal. Now there are two different types of MR cysternography. This is normal MR cysternography without the contrast, where you just make the patient lie in supine position, or you can say the prone position, basically the prone position, and the patient is asked to be in that position, and so that the pressure increases in the intracranial cavity and the CSF may have a leak, and that leak can be detected on the MR cysternography. The only disadvantage of the MR cysternography and the CT cysternography is that the leak can be detected only if it is actively leaking from the skull base into the nose. If it is not actively leaking, it will not show up on the MR and the CT cysternography. That's a huge disadvantage of that. So this patient, I guess, did not have the leak at the time of the cysternography, so I guess it did not pick it up. So anyways, I'm gonna help you read the MR cysternography. So you gotta supposed to go from the extreme anterior aspect to the posterior aspect. So this is the frontal sinus, as I spoke some time back. That's the frontal lobe. That's the right and the left cerebral hemisphere. That actually is the skull. That is the cranial vault actually, and this is nothing but the subcutaneous tissue in the scalp, which is completely different on what you see on the CT scan. So if we go, that's the frontonasal process of the maxilla, which is just beginning, and that's the nasal bone over here. That's the nasal septal cartilage. So if we go on behind, if we keep on going behind, you're gonna start seeing the globe. You're gonna start seeing the skull base over here. You're gonna see the frontal recess over here, and that's the nasal cavity. That's the nasal bulge over here. If you keep on still going behind, you're gonna see the lens over here. As I said, the lens is always gonna be opaque, and this is all the vitreous humor, which is having a hyper intensity look. Okay, so whatever you see over here, the black shadow over here is the orbit, the bony orbit. And if you keep on going behind, you will start seeing the turbinates which appear. The turbinates almost always have a hyper intensity look because of all the secretions they hold and excess vascularity. So they will always appear almost to be iso intense to hyper intense on T2 scans. Now, this is a maxillary sinus, all black in appearance. And this is the most important thing. This is the olfactory bulb over here. What you can see over here, this two structure is the olfactory bulb. Now, initially, some juniors may confuse this to be as the CSF leaking out there, but this is nothing but the olfactory bulb. So the two white bright structures over here is the olfactory bulb and not the CSF, as some may confuse that with a CSF leak, but this is the olfactory bulb area. So if any radiologist, a senior radiologist is watching this video, if you have any doubts in my explanation, or if I'm speaking something wrong, please feel free to interrupt me in the comment section below, and so that we can have a good discussion around here. So this is the olfactory bulb over here, and if we keep on going behind, we're going to see the maxillary sinus, the orbital muscles over here, the periorbital muscles, the turbinates, the ethmoidal region, the skull base still being intact. So far the skull base is still intact. I did not see any discontinuation in between any area. So neither did I see any active CSF leak or any sort of encephalocele or a meningoencephalocele somewhere in the area. So this was pretty doubtful for me, but this is both sides and it is not showing any active leak around here. Most likely this has to be the olfactory bulb in this region around the cribriform plate. So going on still posteriorly, I can see the entire maxillary sinus. Now still the skull base seems to be intact. Nowhere I could see any discontinuation in the black thickness of the bone around here, except for this region, for which I believe this is the olfactory bulb, unless proved otherwise. Okay, so I reached, this is a ventricle over here, that's the CSF in there. So that's the sphenoid sinus. Actually we have reached the sphenoid sinus, and all these black circular structures which you can see is nothing but the branches of the internal carotid. These are the branches of the middle cerebral artery. These are the branches of the anterior cerebral artery. That's the sylvian fissure over here, and that's the middle cerebral artery over here, and that's the sphenoid sinus. So this is how you basically read a basic MRI from anterior to posterior aspect. You can see the actual, you can actually see that this is the cavernous sinus over here. That's the area of the optic chiasm, the optic nerve over here, and the pituitary stalk over here. Okay, and the ventricles. So this is the internal carotid artery, and you can actually see the internal carotid artery being divided into the anterior cerebral artery over here and the middle cerebral artery over here. And this anterior cerebral artery goes in the center, as I spoke in my last lecture about the anterior cerebral artery MRI finding. It will keep on going above in the center. These two are the anterior cerebral arteries, and this is the middle cerebral artery in the sylvian fissure over here. So this is how you actually read for any pathology and anatomy in the MRI scan. Now, I hope so far in this video, if you're still watching this video right now, I hope the concept of the MRI is very, very much clear for you guys. And now, after having this much of your concepts cleared and understanding, I would like to show you all the different conditions which you encounter in cases of the ENT and the skull base surgery. So for example, if I take the case of a mucocele, okay, so before I start showing you the different MRI scans for a mucocele, you should remember this important structure. Okay, so this is the theoretical aspect which you need to take a screenshot of right now. So this is going to be real helpful. Now you have to read this very carefully. Okay, now the MRI signal intensity is highly variable and depends on the proportions of water, mucus and protein. Now the T1 section, the T2 section will appear different for different conditions depending upon the concentration of the water, the mucus, which is a thick secretion, and the protein. This is really important in cases of allergic fungal rhinosinusitis, as the AFRS, and the invasive fungal sinusitis, because there are a lot of fungal debris and proteins such as mucin everywhere. So there will be always a double density sign in a CT scan, but how you can actually identify the AFRS on the MRI scan, for that you need to know this theory part very, very clearly. So we should know that on T1 and T2 and T1 post contrast, in case of T1, okay, the first case is T1. If it is water rich, now we all know that if it is water rich, if the fluid is more, if it's clear water, it will always appear as hypo intense. That is low signal, most common. But it is for protein, it is kind of really opposite of that. So we all know that if the CSF will appear, CSF or any fluid will appear as bright white only on T2 and iso to hypo intense on T1. So the same goes for water, which is nothing but hypo intense on T1, but goes opposite for protein. If there is protein, it will be hyper intense on T1. Okay, it will be high signal on T1. But if it is T2, as we all know, CSF or any liquid which is clear fluid will be hyper intense or bright white on T2 image as shown over here, high signal. But if it is protein rich content, in case of fungal sinusitis, mucin, allergic fungal, it will always be shown as low signal, or I can say hyper intense on T2. This is really important, really important. You need to understand this basic concept in case of MRIs. But if it's a case of T1 scan but post contrast, it will only have a peripheral enhancement and the central hypo intensity. Always remember that. This thing over here, I would say you have to take a screenshot of this and keep on revising this. This is the mainstay of understanding the MRI T1 and T2 and T1 post contrast. This is a mainstay of the MRI. So you need to get this concept very much clear in your brain right now. Okay, so as I said, colonization with fungus can lead to very low signal on both T1 and T2 weighted sequences, mimicking a normal sinus. Okay, now the protein is the mucin, and which is different from the fungus. So the fungus will always appear as low signal on T1 and T2 both. So if you are getting an MRI, so if a patient comes to your OPD with only the MRI but not the CT scan, so some guy does an MRI and the patient is having AFRS or maybe invasive fungal, so on T1 and T2 both the fungus will appear as hypo, very low intense. Okay, this is really important. But on T1 the protein will be high intensity, and on T2 the protein will be low intensity. This is like really important. Okay, so I'm going to show you the scans for the mucocil right now. Now this is the T1. Okay, this is a T1 scan because the vitreous humor is black, dark. This is, you can see over here, a huge frontal mucocil, and which is also iso intense to the T1, because now normally had this been full of clear fluid, it would be still dark, and on T2 it will be bright white. So as we spoke about some time back, this has to be hypo intense on T1, which is basically nothing but the clear fluid. So there you cannot see any place of hyper intensity, so there is no protein here, so there is no fungus as well. Sorry, not fungus exactly, but there's no mucin, so there's no chance of AFRS in this patient. But this is in case actually a clear fluid on T1 without any hyper intensity over here. So the next photograph is nothing but the same axial T1. You can see this is actually a mucus retention cyst and not a mucocil. So but still the concept remains the same. This is clear fluid, and that's why on T1 it appears to be as hypo intense, because the fluid on T1 will be hypo intense, on T2 it will be hyper intense. Okay, and this is still an MRI. So moving on further, if I can just zoom this for you guys. Okay, so this is the lesion over here. This is still the T1 post contrast. Now this is a post contrast over here, and as you can see over here, this is the left side over here. We have a peripheral enhancement. Okay, so as we saw some time back, mucocil and the AC polyp on MRI scan post contrast T1 will have a peripheral enhancement and a central hypointensity. Why? Because the central part is full of fluid, and the fluid will always appear as T1 dark, and the peripheral enhancement is because of the capsule, which has got mucus and which has got protein. So that is peripheral enhancement on T1. That is a basic concept which lies behind the MRI post contrast T1 image. So moving on further, this is yet another photograph. Now this is a flare image. That's a flare image of the mucus retention cyst. Flare is nothing but T2, except for the fact that the fluid in the CSF and the vitreous humor will appear dark. Okay, so this is the same thing, mucus retention cyst, T2 scan. Now this is a T2 scan. The fluid is appearing as bright white over here, as we spoke earlier. Now this is the same thing. This is T2 as well. This is a T2, but in this case, this is a left side frontal mucosal having the same intensity of that of the vitreous humor, suggesting that this is clear fluid, and this is also clear fluid, and this is nothing but the T2 scan suggestive of the frontal mucosal. Also, you can see a lot of retained secretions in the maxillary sinus over here. So that is indication of that it is a T2 scan. Okay, so moving on further ahead. So, okay, this was... Okay, so this was about the mucosal, and this photograph was really important. You should know the basic concept of that. So moving on to the second case after mucosal is the inverted papilloma. Now the inverted papilloma, before I start the inverted papilloma, you should know the concept of how the inverted papilloma looks like on the MRI scan. Now on T1 scan, the inverted papilloma looks iso-intense to muscle. So this is really important to understand. It may be really important. It appears as iso-intense to muscle, the inverted papilloma. Okay, and on T2 we have generally it is hyper-intense, and along with alternating hypo-intense lines. Now this concept is really important. Even before operating the patient, even before sending the sample for biopsy or frozen, we will with the help of MRI scan, we can diagnose the patient to have the inverted papilloma. How? I can explain you in some time. So the T1 post contrast with the gadolinium will always show hyper intensity, heterogeneous enhancement with yet again the alternating hypo-intense lines. Now I'm going to show you the MRI scan of the patient. Now this is basically a T1 image of the patient. Now why? In this case you're not able to see the globe, no vitreous humor, no CSF, but still why this is T2? Because the brain parenchyma, the white matter, is appearing as white. So this is how you can identify that it is T1. So you can see a mass over here. If I can just zoom this for you guys, you can actually see a iso-intense mass with alternating hyper and hypo-intense within itself. So you can see a streak, a bands within the mass, and this is iso-intense to muscle, which you can see over here, exactly same intensity of the muscle. And if I show you a T2 scan of this patient, this is a T2 scan. You can see the vitreous humor hyper intense and the CSF bright white. So if I can zoom this for you guys, you can actually see that there is hyper intensity. You cannot call this as enhancement because this is not post contrast. This is just normal T2. You can see the hyper intensity. So as I said some time back, that on T2 it is generally hyper intense to muscle. So the same thing we can see over here. This is hyper intense to the muscle, and this is what is the inverted papilloma with the alternating hypo intense bands. Now the basic concept in the MRI, the role of the MRI in the inverted papilloma is really huge. So because even before you start the operation on the MRI itself, you can diagnose the patient to have the inverted papilloma. Now, as you can see over here, if I can just zoom this for you guys, you can actually see the streaks. You can actually see the streaks over here. That's the hypo-intense streak and the hyper-intense area over here. This is called as the cerebriform convoluted patterns. That's the CCP. Okay, that is called as the CCP. That's again called as the cerebriform convoluted patterns. Now whenever there is the presence of CCP, that's the hyper intense and the hypo intense alternating bands, it is quite suggestive of the inverted papilloma. Also, with the help of this MRI, we can identify the site of origin of the inverted papilloma. Now as you can see over here, the mass is present in the nasal cavity as well as in the maxillary sinus, the entire maxillary sinus. Now, the area where the CCP arise and disperse away, the area where the CCP arise is usually the site of origin. Okay, the area where the CCP, that's the cerebriform convoluted pattern, arises is the area of the origin of the mass. So you have to take into consideration that while doing the surgery, you have to remove that part of the area where that origin takes place from. Also, sometimes the inverted papilloma invades, not sometimes, most of the times, the inverted papilloma invades the Haversian canals, the bone marrow of the bone underlying. So the area of the origin. So for me, I think this looks like the area from where all the CCP is arising from here. So I think this has to be the site of origin. Okay, so we have to remove and drill the bone, because if you do not drill the bone, now the inverted papilloma, though being a benign tumor, it is an aggressive tumor and may have a recurrence if you do not remove the underlying bone at the site of origin as well. So you have to bear that in mind. So the MRI plays a real important role. Also, the third point of the importance of MRI lies in that, see, when you're doing a surgery, in cases of inverted papilloma, you take a surface biopsy, it's of no use because it's going to be polypoidal in nature. You have to take a deeper biopsy, so that the place of taking the biopsy you can know for sure from the MRI itself. Now I can see a lot of CCP patterns over here. They are arising from this region and going away like this towards the nose area. So I think this is the main area from where the tumor is arising. So I should take a biopsy from this place, and this will be more valid for my biopsy. If I take a biopsy from somewhere here, which is going to be polypoidal in periphery area, this is going to be useless. So I need to take a biopsy from this region going in the maxillary sinus, and taking a biopsy from this region and nowhere else. So also the third point is that if the inverted papilloma, now inverted papilloma has a huge propensity, I guess 1% chances that it can convert into the squamous cell carcinoma. So how to identify that the tumor from benign has undergone the conversion into the malignant transformation? So you have to locate for the CCP. Now this origin is this is a place of the origin, because here, from here, I can see all the CCPs arising and going towards the nasal side. Now the tumor in general will have CCPs all over the tumor. Okay, the place where the CCP is absent, where the place you cannot see the CCP at some area and you can see it in other areas, the place where you cannot see the CCP, in short, loss of CCP denotes malignant transformation. So that area should be taken for biopsy to know for sure that this patient has undergone malignant transformation and should be sent for frozen section. So this is how the importance of MRI is in cases of inverted papilloma cases. So I hope this is very much clear. So we spoke about the mucocele, we spoke about the inverted papilloma. Now moving on towards the third one, which is the JNA. The JNA, now this is really important for the students of how to identify JNA on a CT scan and on an MRI scan, because JNA is a highly vascular structure. It will always appear on the MRI as hyper intense on T2, along with phlovoids, and post contrast will always 100% show prominent enhancement. Mostly all tumors which are aggressive, highly vascular, all malignant tumors which have got a lot of blood supply to them will always show huge post contrast enhancement. Okay, this is a basic concept in your MRI scans. Mostly the tumors on T1 scan will show iso intensity to hypo intensity. Okay, mostly all the tumors, mostly, not all tumors, but mostly tumors will show T1 hypo intensity or iso intensity. But on T2, it will show heterogeneous signal along with the blood vessels. It may show hyper intense, may show sometimes hypo intense, depending upon the vasculature and the protein content and the calcification and within the tumor. So that depends on the individual tumors. You have to be very careful of, but the T1 post contrast, if it's a vascular tumor, will always show enhancement. But in cases of in cases of invasive fungal sinusitis, now where the most common example is a mucormycosis. The mucormycosis will cause plugging in the vasculature once it invades. So that will block the blood supply. So the gadolinium cannot enter into those blood vessels. So that will cut off. So the MRI scans post contrast will not show any enhancement, suggestive of the necrosis being taking place. So that is also how you can study the MRI scans in different conditions. So coming back to JNA, the T1 scan will show intermediate signal, T2 will show heterogeneous signal, hyperintense signal with flow voids which appears as dark. Because it has got a lot of blood supply, it will always show as a flow voids because it is not under contrast. So it will always show flow voids. And in case of post contrast, it will show a lot of huge enhancement. Okay, so we have a typical salt and pepper appearance. Now this is an MCQ question for all the ENT students and all the MBBS students, or for appearing as NEET exams. Okay, so the salt and pepper appearance will be seen in JNA on MRI scan and not on CT scan. Okay, why salt and pepper appearance? Because of the flow voids which you can see along with the hyperintense signals. So the MCQ becomes like salt and pepper appearance on the MRI scan because of the blood flow void, and that too in JNA. Okay, this is really important. You can take a screenshot of that. So moving on to the scans of the JNA, this is a sagittal section where you can see the this is a sagittal section. This is a normal JNA which is actually pushing to the skull base but not invading it. It is actually extradural. So this is one photograph of the JNA. This is actually T1 because the CSF is not bright. That's normal T1 scan. Mostly it looks like post contrast because I think you can see a lot of blood, hyperintense blood vessels around here. I think this is a post contrast image T1, so you can see the hyper enhancement of the tumor of JNA in this region with somewhat black shadow in between. So that's the T1 post contrast sagittal scan. This is a T1. You can see the tumor over here. That's the T1 scan. That's the tumor over here. And this is yet one more photograph of the T1 scan, a normal T1 scan. Okay, this is also an axial section or T2 scan of the JNA. Now you can actually see hyperintense areas and flow void areas. Now this is what I was talking about, the salt and pepper appearance. Now, if you give a contrast gadolinium, it will have a post-contrast enhancement and no longer it will show flow voids, right? It will appear as hyper enhancement. But as you can see in this photograph over here, I hope you can see this on your screen right now. You can actually see, follow my cursor, you can actually see a lot of small areas of black areas. This is all about the vasculature. These appear as flow voids and the tumor appears as the hyperintense on T2. So we're going to have the hyper and hypo, so salt and pepper appearance alternate. This is we get on T2 MRI scan. This is the angiofibroma. This is how you can see the flow voids over here in this case. So moving on to further different photographs over here. Now this is a patient whom I had in my teaching career. So you can see this is a T2 scan of the patient. Now I took a lot of axial and sagittal and coronal sections of the JNA. This patient had a huge JNA. You can see this is a T2 scan and this is the hyper intensity of the tumor over here. This is a collection. You can actually see the tumor over here. Now, whatever you see with the same intensity of the vitreous humor has to be the collection like fluid mucus retention. So if I can just zoom this for you guys to have a better understanding. This is of the same intensity, okay? This is of the same intensity. So this has to be the mucoid secretions or the collections, secondary collections because of the obstruction. Now, if I can show you the actual mass of the GNA over here, you can actually see this mass over here protruding inside. This is much better over here. You can actually see this is a T2 scan, and you can actually see a lot of flow voids in between. Now this is a very clear picture for the flow voids. Now this is a typical salt and pepper appearance on the MRI scan. You can see a lot of flow voids, a lot of blackish flow voids along with the tumor. You can see that this is a typical salt and pepper appearance. You can see a lot of blood vasculature. You can just imagine the amount of blood vessels within the tumor, and the size of the tumor is so huge. It is actually present intranasally within the maxillary sinus, the pterygopath and fossa. It is actually going to the infratemporal fossa and in the orbit as well. So it is having a lot of orbital component, the infratemporal component. It's a huge GNA that we had to operate on. You can see a lot of flow voids in between the tumor. You can just imagine the amount of blood vessel, the vasculature of this patient's GNA. So this is how we can identify the GNA. This is the secondary mucosal collection on the opposite nostril, the inferior turbinate. So if I can just show you the second photograph of this patient, this is a T2 scan. This is the same scan. You can actually see the extent of the tumor. Now, we can actually see the Hallman-Miller sign as well on the MRI, because you can actually see the tumor invading and abutting the posterior aspect of the globe. You can actually make out that the posterior surface of the globe is kind of pushed a bit anteriorly. This is not at the same level. You can actually appreciate that the globe is being pushed anteriorly. The patient also had proptosis because of the immense pressure from behind. Now you can actually see that this is a maxillary sinus of the left side, and the maxillary sinus of the right side is actually completely obliterated, that the patient's posterior wall of the right maxilla was almost completely destroyed, and the tumor was actually coming out from the posterior wall of the maxilla and going on to the anterior wall of the maxilla, almost abutting the entire right maxillary sinus over here. You can actually have a look on how the entire GNA is obliterating the right maxillary sinus. So once we opened the right maxillary sinus endonasally, and from the external approach, the tumor was just lying there in the sinus, also having so the tumor was also entering through the inferior orbital fissure and also going to the infratemporal fossa. So this patient also had a huge cheek swelling. You can clearly see that this is a maxillary sinus over here, and this is a maxillary sinus on the left side. So this is the left maxillary sinus, and you can appreciate the posterior wall of the left maxillary sinus, but the posterior wall of the right maxillary sinus is somewhere around here. So that's a huge Hallman-Miller sign for this patient over here. And as you can see, this is the muscle. So the tumor is actually hyper intense to muscle. You can actually see that the posterior wall of the maxillary sinus is being breached over here, and it is entering actually into the maxillary sinus over here. You can actually appreciate the posterior wall of maxilla, which is covered with the secretions. You can actually see the breach over here in the posterior wall of maxilla, and this is the exterior cheek area for which the subcutaneous tissue is there. There was cheek swelling. As you can see over here, there's a lot of cheek bulge over here. If I can show you a different photograph on a different scan, different section. Yeah, this is a coronal section for the patient. Now, this is a coronal section. You can actually see the inferior margin of the orbit is being abutted, and here you can actually see the infratemporal fossa being affected. That's a huge spread in the infratemporal fossa via laterally, and this is the inferior aspect of the orbit being invaded. And you can actually see the invasion over here. Clear-cut invasion. You can see the invasion happening over here. This is basically towards the area of the spinoid, and that's the area of the orbital apex, and that's the temporal lobe. You can see you can actually see the spinoid collection, spinoid sinus full of collection because of secondary sinus obstruction over here. So this is how you should be so fluent in, you know, identifying the MRI scans very fluently. So this is a tumor over here, and you can actually see the tumor entering through the inferior orbital fissure over here. This area is the area of the pterygoparietal fossa, the spinoparietal foramen, and above we can have the inferior orbital fissure. So this is how you should be able to read a scan. And yeah, this patient also had the cavernous sinus compression. Now, as you can see over here, this is the internal carotid artery. Now, this is really important. Whenever you're operating a JNA, a huge JNA like this, you need to always make sure that the vasculature is intact. Now, you can actually see this is the internal carotid artery. That's the internal carotid artery. That's the sphenoid sinus. That's the cavernous sinus over there. This is a tumor, and that's the collection over here, the secondary collection. Now, the internal carotid artery seems to be completely normal and intact. And this is the internal carotid artery being divided into the anterior cerebral, and this is a middle cerebral artery over here. So this is the proper, the internal carotid artery is nowhere affected by the tumor. You can see the petrous part. Not the petrous part, that's the cavernous part of the ICA. That's the cavernous part of the ICA, still not affected, still normal. So I think the internal carotid artery in this patient is completely normal. Okay, so this is how you should actually read the JNA scans. So that was the third case. Now moving on to the fourth case is a nasopharyngeal carcinoma. Now, the nasopharyngeal carcinoma, you should always remember that the T1 will always show it to be as iso-intense to muscle. Now, mostly all the carcinomas on T1 are either iso-intense or hypo-intense, mostly iso-intense, and on T2, they somewhat may appear as hyper-intense, mostly, and in some cases may appear as hypo-intense, depending upon the content of the tumor. So this is what the MRI looks for a nasopharyngeal carcinoma, or any nasopharyngeal carcinoma where there is huge destruction of the bone and soft tissue compression. So we have few more cases. This is a case of the olfactory aesthesia neuroblastoma. Now, as you can see over here, this is a case of the olfactory aesthesia neuroblastoma. Now, this is a case of T1 post contrast. Now, why T1? Because we cannot see CSF. Nowhere we can see CSF, and whatever we can see here is the brain parenchyma, which is kind of white. That's how we can differentiate that's T1. Why post contrast? Because I can see small areas of blood vessels being enhanced over here. So that is how I come to a conclusion that this is a post contrast T1, and because of the contrast, you can see the patient's the post contrast enhancement is huge. This is a huge intracranial component. The skull base, as you can see over here, the black line is having a huge discontinuation over here in this region, and this is on actual both sides. So maybe in case of, now normally olfactory neuroblastomas commonly have septal involvement. They destroy the septum and midline. So maybe in this patient they may have it may have destroyed the septum and midline and may have crossed on both sides. So this is having the same hyperintensity over here. Second, we have the other scan as well. Now this is the T1 scan, same T1 scan but normal without contrast. And as you can see over here, this is a medial rectus, that's the lateral rectus, that's the optic nerve. And as you can see over here, the olfactory neuroblastoma, which is actually a malignant tumor, is how much compressing on the left eye globe. It is actually compressing the entire globe towards the left side, and you can actually see the optic nerve being compressed on this particular region. That's the lateral rectus muscle over here, and you can actually see the optic nerve being completely compressed on this side. So I think this has a huge invasion into the left orbit. And as we all know, the aesthesia neuroblastoma is actually a malignant tumor. So we may have to do a orbital exenteration in this patient if at all needed to prevent the recurrence and the distant spread. So this was the second photograph, the axial section. This is yet the T2 section, because we can see this is a T2 section. Not much clear though, so I don't know, this is not much clear, so I'll show you one more photograph. Yeah, this is a T2 section, because the white matter is dark over here, and the tumor is actually, you can see the invasion. The breach can be seen very easily. That's the T2 secretion, which is hyper intense on T2, and the tumor is appearing as hypo intense to the muscle, or you can say slightly hyper intense to muscle. Not much, but this is a T2 image. That's the olfactory aesthesia neuroblastoma. So this is how you can differentiate the different tumors. Now this is the T1 post contrast. Now the tumor has taken up the contrast, and you can see this is the optic nerve. So in this patient, the optic nerve is kind of intact, but the medial rectus muscle is being compressed on this patient by the olfactory neuroblastoma, and we can see the secondary spinoid collection over here. So this was about the aesthesia neuroblastoma, for which we use the Kaddish classification of the grading system for surgery. So I'll be doing a different separate video for the Kaddish classification as well. So moving on, then we know that the AC polyp has similar features to the mucosal peripheral enhancement and all that. CSF leak, I spoke about the MR cysternography and the various complications of using gadolinium, though it's the safest drug to be used, but if used in excess amount, it can have a huge complication. Also, we know that the intrathecal fluorescein is banned in India, so we cannot use that for CSF leak detection. So we can use the gadolinium instead of the intrathecal fluorescein, because the fluorescein can have complications such as the meningitis and various complications like that. So I think I've covered almost all the MRI scans in different conditions and the different basic aspects of MRI. So I really hope you like this video. If you are still watching this video this late, I really appreciate you guys. Then I hope the concepts are really clear, and in the next video I'll be talking about how to read a CT scan PNS on a sagittal scan and on axial scan, because I've done the coronal sections a lot of times, so I'm getting a lot of requests to teach them the sagittal and the axial scan. So I'll be doing that in my next lectures. So till then, if you like this video, leave a like behind and subscribe to my channel. Till then, take care guys, be safe.